Khandeparkar sir, you can go live now.
Good afternoon, my dear doctors. On behalf of Hetero Healthcare, I, Dr. Prashant Khandeparkar, welcome you to this webinar on PPH management then and now. Doctors, at Hetero, we market products in multiple therapy areas, like for example in gynecology, dermatology, orthopedics, pulmonology, etc. We have a very strong R&D support, and we have developed products and formulations keeping patient benefit in mind. Doctors, our endeavor is always to develop formulations which will improve patient compliance, ultimately hoping for better clinical outcome. We have developed NSAID patches, we have developed rivastigmine patches to improve patient compliance and to reduce the burden of adverse effects. At Frenza, gynecology, obstetrics, and IVF is an important therapy segment for us. We have marketed products for vaginal health like Feminora, Pelitra. We have conventional tablets like Didropal, Milotin. Recently, we have introduced a lactic acid vaginal film under the name Celero. We have recently introduced Carbetocin under brand name Carbiac for PPH. PPH, doctors, as we know, is a life-threatening condition and requires intense and immediate management. PPH management itself has undergone changes over a period of time. To speak more about PPH prevention, PPH management with Carbetocin, today we have Dr. Swetal Mahule with us. Dr. Swetal Mahule has done her MBBS from GMC Nagpur, DGO from prestigious KM Hospital, Mumbai. She's a consulting obstetrician and gynecologist at Rani Avatibai Multispecialty Hospital, Gondia. Madam has been practicing for 7 years in Gondia, a special interest in obstetrics and infertility. Over to you, madam, for your insights on Carbetocin and PPH management. Welcome once again.
Thank you, sir. Namaskar. Myself, Dr. Swetal Mahule. I am a consultant obstetrician and gynecologist at Rani Avatibai Multispecialty Hospital, Gondia. Thank you for inviting me here to speak here on Carbetocin, which is a smarter, superior, and safer choice in PPH management. Here we all know about the postpartum hemorrhage, which is a very unfortunate yet common thing. We all know about it, which is a leading cause of maternal mortality, which accounts for 35% of all maternal deaths. Maternal mortality ratio is 240 per 1 lakh live births compared to 16 developed countries. The global incidence of PPH is around 14 million women suffer from PPH, and which is 2 to 4% of all vaginal deliveries and 6% of cesarean sections. Globally, 38% of maternal deaths occur due to PPH. This is 21st century, and we are here that 38% of maternal deaths are due to PPH. So we are talking here about this. The impact of postpartum hemorrhage is that it increases the hospital stay, higher inpatient mortality, major impact on the live birth and health of the affected and their families, long-term psychological impact on affected women. Clinical finding, we all know there is a degrees of shock, which is compensated blood loss, which occurs normally mild to moderate and severe blood loss. In mild blood loss, there is 1000 to 1500 ml with slight fall in BP, which with signs and symptoms of weakness, sweating, and tachycardia. In moderate blood loss, 1500 to 200 ml of, that is 25 to 35% of total blood volume. Marked fall in BP with restless, pallor, and oliguria. Severe blood loss, this is the most important thing, which we have to manage aggressively, 2000 to 3000 ml of blood loss with profound blood pressure fall with collapse, air hunger, and anemia. Most important thing is diagnosis of PPH through initial evaluation, then examination at the time of PPH, and laboratory assessment. Initially, we should rapidly assess the patient's status, its tachycardia, hypotension, and vital signs and blood loss. Firstly, we should assess the entire genital tract after delivery for lacerations, hematomas, signs of uterine rupture, manual examination for RPOCs, that is retained products of conception. Also for non-contracted uterus, that is flabby uterus, to check, and also for the uterine inversion. We can also do, if there is availability of bedside ultrasound for hemoperitoneum, which can cause more and more blood loss. Laboratory assessment with complete blood count, hematocrit, platelet levels, coagulation studies, and assessment of fibrinogen and other coagulating deficiencies. Now, what are the challenges in diagnosis of PPH? First and foremost is the loss of blood. After delivery, we should assay it through the visual estimation of blood loss. Delay in diagnosis is the most important thing. If we delay by 5 to 10 minutes, then the more and more delay will cause more and more harm. So first is challenges is delay in diagnosis. We should train our staffs to early pick up, and also we should monitor the patient. And we all know that PPH can occur without any identifiable risk factors. So we should consider every postpartum and every intrapartum patient as a high-risk patient. Visual estimation and then under and overestimation of blood flow is also very important, because for underestimation, we will lose the patient. For overestimation, continuously we will get the call from the our post-monitoring systems. Complications associated with postpartum hemorrhage. What are the complications? The most important, I already discussed maternal mortality, dilutional coagulopathy, myocardial ischemia, blood transfusions, anemia, and fatigue. Postpartum depression, which is also nowadays very common. Anterior pituitary ischemia with delay and failure of lactation. We all study during our MBBS, during our PG days, about the active management of third stage of labor. That active management can speed up the delivery of the placenta and lowers the risk of heavy bleeding after birth by injection of uterotonic agents for contraction of uterus. Delay the clamp. We should delay the clamping of cord for at least 1 to 3 minutes and perform control cord traction. If required, we should assess the uterine tone immediately. We should always do this practice to assess the uterine tone and ensure the contracted uterus. A large WHO-directed multi-center clinical trial has highlighted the use of uterotonics as the most important active management of third stage labor. Now, we'll see about the prevention of postpartum hemorrhage. We all know that is the most important factor we should practice is to improve the health status of the mother and girls, adolescent girls and mothers. That is, during the ANC, we get 9 months before delivery. So we should improve the hemoglobin status more than 11 grams per percentage. We should identify and the high-risk women, plan for institutional deliveries. As always, strict vigilance for high-risk and all women in third stage of labor. Active management of third stage of labor in all patients. Examination of afterbirths, that is complete placenta is removed or not. We should examine the afterbirths. It should be a routine practice. Explore the uterovaginal canal after difficult or instrumental and destructive deliveries. Now we will study about uterotonics and timing and how to use it. There are many molecules like oxytocin, carbetocin, ergometrin, syntometrine, and misoprostol. And what time we should use at the crowning of the baby's head, or at delivery of anterior shoulder, or at the second stage of labor, following the delivery of the placenta. Prophylactic use to prevent PPH and active management of third stage of labor. Management of PPH means therapeutic use. Now, treatment. Some women still require treatment even if we prevent PPH occurrence, despite active management of third stage of labor. Postpartum hemorrhage treatment may be required where no preventive agents are available or after failure of prophylactic use of uterotonic drugs. Like we use this uterotonic drugs. We all know about this. We should not delay the use of these drugs. If there is more than less than 500 ml, then there will be no symptoms. Then 500 to 1000 ml, and we should always monitor the blood loss by these signs and symptoms. What are the challenges in the current therapies of PPH management? Like we always having this oxytocin, which needed appropriate training of the clinical staff, regular patient monitoring. Oxytocin has a shorter half-life of 3 to 5 minutes only, and it requires a long, continuous infusion. Syntometrine significantly increases the elevated risk of elevated blood pressure. We cannot give this to a patient having preeclampsia and gestasis, nausea and vomiting. It increases nausea and vomiting. Oral misoprostol, sometimes it increases the risk of PPH, increased need for additional uterotonics, greater incidence of nausea, vomiting, shivering, diarrhea. Methylargometrin significantly increases the nausea and vomiting. WHO recommends the use of oxytocin as an effective uterotonics for the prevention of PPH during third stage of labor in all births. To effectively prevent PPH, only on uterotonics should be used. Only one uterotonic should be used. Either of these. What is the rationale for the development of carbetocin in new heat stable formulation? Now, carbetocin, earlier previous formulation of carbetocin should be stored at, it requires the storage of 2 degrees Celsius to 8 degrees Celsius. But now, it is available in a room stable temperature formulation and convenient fire profile presentation. Even oxytocin requires it requires a refrigeration, and it is heat stable formulation of oxytocin is currently not available in a country like ours, where always there is no cold chain transport and storage capabilities. We require a formulation which is heat stable, which should be room stable and has a high shelf life of 24 months at 30 degrees Celsius and 75% humidity. It avoids the need for cold chain storage and logistics, and it is provided in a vial formulation. Room temperature stable carbetocin we now have. Now, the most important chart is this. How carbetocin works. This is an oxytocin molecule and this is a carbetocin molecule. Carbetocin is a synthetic, long-standing analog of oxytocin. It's an analog of oxytocin. Some substituted means this molecule is substituted with the methyl ether group, substituted with this CH2 and separated with the hydrogen atom, and now this carbetocin is formed. This is important. Mechanism of action. This receptor binding. This carbetocin receptor binding. This is the receptor and this is the carbetocin. Here it binds to the carbetocin receptor. It causes activation of phospholipase C and generation of second messenger. This is IP3 and diacylglycerol. Now, this IP3 induces the release of free calcium. This free calcium from intracellular side to the extracellular side. Now, this intracellular calcium, which has came from here inside, this causes binding of this calcium to calmette, and this stimulates the uterine smooth muscles by activation of uterine smooth muscles by activation of this myosin light chain kinase. So, this uterine contractions occurs. Strong uterine contractions. With a single IV dose of carbetocin of 100 microgram administered after the delivery of the baby is sufficient to maintain adequate uterine contraction, preventing uterine atony, excessive bleeding with the efficacy comparable to the hours of oxytocin infusion. Now, we will talk about the benefits of heat stable carbetocin over oxytocin. This is a charting showing comparison between the onset of action, duration, and half-life. With the IV use of oxytocin, we were getting almost immediate effect. Carbetocin IV dose require 1 to 2 minutes of effect. Intramuscular 2.5 to 2.3. Duration of action of oxytocin is immediate. It works immediately and it loses this immediately. Its half-life is also only 3 to 5 minutes. But carbetocin, it starts onset of action in 1.2 minutes. Then duration of action is through IV doses 60 minutes. That is 1 hour. And half-life is more, 40 minutes. Through intramuscular use, we can get a duration of action for 2 hours, 120 minutes, 190 minutes, and half-life of 40 minutes. And see, the oxytocin half-life is only 33 to 5 minutes. So, a single IV injection of carbetocin achieves uterine activity within 2 minutes and lasts approximately 1 hour with the IV use. Carbetocin can increase the rate and force of spontaneous uterine contraction, tonically contracted uterus. So this is a thing. Reduced need for additional uterotonic agents, longer half-life, no cold storage required, similar efficacy that of the oxytocin, good tolerability of the patients, and similar onset of action. Onset of action is nearly similar. What are the benefits of heat stable carbetocin over oxytocin? See, oxytocin displays a higher structural similarity to vasopressin, which is a hormone involved in the regulation of water reabsorption. Water retention in the body can lead to disturbance in sodium level. Oxytocin has antidiuretic effects, and IV infusion may cause water intoxication, an acute form of hyponatremia. Water intoxication has been reported in women treated with oxytocin for PPH, which already has a hypovolemia, then water intoxication, induction and augmentation of labor and abortion, where we use oxytocin. Now, that's why carbetocin is superior, as it has a 24-fold less potent than oxytocin at the vasopressin V2 receptors, reducing the risk of hyponatremia. Till date, no cases of hyponatremia has been reported in the literature for carbetocin. Clinical evidence. Efficacy and safety of carbetocin versus oxytocin. There is a champion trial which suggests about the carbetocin non-inferior to oxytocin. These are many studies are there. First study, there was a large clinical trial in the prevention of PPH, Carbetocin hemorrhage prevention, which was conducted by WHO Department of Reproductive Health and Research. It was a double-blind randomized control trial, non-inferiority trial, where the objective was to compare the effectiveness and safety of investigational heat-stable carbetocin to oxytocin in the prevention of PPH after vaginal birth. Number of cases was there 30,000 women across the 10 countries, including India. Primary outcome of this study was the proportion of women with blood loss of at least 500 ml or the use of additional uterotonic agents. The proportion of women with blood loss of at least 1,000 ml. What was the study? WHO champion study. Here, there was the carbetocin and oxytocin. Blood loss of more than 500 ml with the use of additional uterotonic agent. Nearly similar, which means that it is non-inferior to the oxytocin. And here also data suggests that non-inferior if the blood loss is more than 1,000 ml. And nearly adverse events were similar. Carbetocin decreases the need of uterotonic agents as compared to oxytocin. Oxytocin requires other uterotonic agents like methyl ergometrine and misoprostol. But when we use carbetocin, we need only carbetocin. This was studied by a meta-analysis of 5 trials. In this, 617 patients in carbetocin group and 597 patients in oxytocin group. The outcome was the need for the need of additional uterotonic agents. So the study results were 28.20% of patients treated with carbetocin, whereas 51.59 patients of oxytocin treated required additional uterotonic agents. The pool incidence of blood transfusion was 2.17% in carbetocin group and blood transfusion was required 5.95% in oxytocin groups. So patient treated with carbetocin has less need of additional uterotonic compared to the treated with oxytocin. Single dose carbetocin via continuous infusion of oxytocin. Here, there is hemodynamic effects of oxytocin and carbetocin were studied, and they are compared and their efficacy was assessed in terms of blood loss and additional uterotonic needed in cesarean section. This study has a sample size of 51, received a bolus of 100 microgram IV at the time of delivery. Here, the other sample size, same sample size of 51 cases, received 20 international units of oxytocin in 1 liter of 0.9% saline solution IV at delivery. These both sample size patients, early hemodynamic effects were assessed as an impact on blood pressure, need for additional uterotonic agents, blood loss, and drop in hemoglobin. Additionally, blood pressure, uterine agent, uterine tone, position were monitored at the 2 hours, 12 hours, 24 hours, and after delivery. This was the result. At 2 hours after cesarean section, 12 hours, and 24 hours. So, treated with oxytocin shows greater reduction in blood pressure. Both hypotensive, but greater reduction in blood pressure was with oxytocin. Significantly, am I audible? Hello?
Yes, ma'am.
Okay. Significantly, more women treated with oxytocin needed additional uterotonic agents compared to those treated with carbetocin. Patients treated with carbetocin showed better uterine contractility at 2 hours, 12 hours, and 24 hours after statistically significant difference, which shows a statistically significant difference. RCTs comparing carbetocin with oxytocin. There are many RCTs, and one of those shows the effectiveness of carbetocin was compared with oxytocin. 1210 patients for at least one risk factors for PPH, single IV bolus of 100 microgram of carbetocin or oxytocin 20 international unit as a 6-hour infusion was given. Then it was compared. Result was management with carbetocin is associated with a greater reduction in PPS as compared to oxytocin. Carbetocin as a good alternative in PPH, prevention high-risk cases. Study design, it was a randomized double-blind control study, single-center prospective study. Patient enrolled was 314 for carbetocin group and 310 in oxytocin group. Outcome was blood loss of at least 500 ml within 24 hours postpartum. This study was showing 4% of the sample size has a uterine bleeding. In oxytocin group, it was 13%. 2% of patients were having prolonged third stage of labor. Here in oxytocin group, it was 6%. And this we can compare it. So carbetocin significantly decreases the risk of manual removal of placenta, especially in women with induced and augmented labor. It also significantly has a probability, 83.1% probability of being the best agent to reduce the PPH of more than 500 ml after vaginal delivery. The advantages of its application at the end of third stage of labor was that decreases the need for uterine massage, which we always do, and need for other uterotonics, and narrowed the hemoglobin form. Postpartum hemoglobin level is very important for many things. Comparison of carbetocin with oxytocin for the need of other interventions. This comparison of prophylactic effect of carbetocin versus oxytocin for the prevention of uterine atony in patients undergoing elective section. And its efficacy was measured in terms of need of additional uterotomies. Carbetocin, this dose was given and the sample size was 462. Oxytocin dose and sample size was more 1122. Only 3% of this group of carbetocin given required additional uterotonic treatments as compared to 7.2% of oxytocin taken group. So carbetocin was the most effective compared to the oxytocin 5 international unit bolus subgroup. 5 international unit bolus. So this is the result. Efficacy and safety of carbetocin vs Syntometrine. Now we have compared carbetocin with oxytocin. Now we will be comparing it with Syntometrine, which is efficacy and safety of single intramuscular dose of carbetocin vs Syntometrine in management of third stage of labor following vaginal delivery was assessed in women with a low risk of leakage. 240 women with a healthy singleton pregnancy, and now either of this Syntometrine and carbetocin was administered as single dose intramuscular injection following vaginal delivery. Here we are using carbetocin as an intramuscular injection. Earlier we are using it as an IV injection for comparing it with oxytocin. Now intramuscular. Assessment, what we were assessing: requirement of additional uterotonic, incidence of PPH, amount of intrapartum blood loss, and adverse effect of it. So what we found: significant difference between the mean blood loss. In Carbetocin group, we were getting 224, 210, plus minus 110 ml of blood loss. In Syntometrine group, there was more blood loss. Better hemoglobin level on the postpartum day 1. This is more important. Lesser mean drop of hemoglobin level at 24 hours after delivery. So reduction in the PPH, postpartum blood loss, smaller drop in hemoglobin levels, lesser adverse effects makes carbetocin more effective than Syntometrine. Also, carbetocin has comparable safety profile than oxytocin, as according to this medical dictionary for regulatory activities, GI disturbances with oxytocin like nausea, vomiting. This is for oxytocin, which should be for Syntometrine. Headache, leukocytosis. Adverse effects. Carbetocin has a comparable safety profile than oxytocin as these zeros. We can use carbetocin even if the patient has some heart diseases like arrhythmias and palpitation. 0% of incidence of adverse effects with carbetocin as compared to this oxytocin. Vascular disorders like fall in blood pressure. This is a result. Skin rashes, no patients are getting skin rashes. And these are the results. Carbetocin, a promising agent for PPH prevention. Efficacy of carbetocin was checked against conventional uterotonic agent for the prevention of PPH. Carbetocin was compared with oxytocin, Syntometrine, and or placebo, which when given intramuscularly after normal vaginal delivery and CST. Effectively compared with conventional uterotonic agent and statistical significance reduction in the need for therapeutic uterotonics compared to oxytocin in cesarean deliveries. Low risk for PPH, reduced need for uterine massage compared to those treated with oxytocin after vaginal and cesarean delivery. Lower blood loss compared to those treated with Syntometrine. And intramuscular administration of carbetocin at a dose of 100 microgram, which is a single vial of carbetocin, is more effective than oxytocin for preventing PPH. Its use is associated with a lesser blood loss and better tolerability profile as compared to Syntometrine. This is the slide showing comparison of carbetocin with Syntometrine. Different studies have been conducted. So the results were in women who underwent CS deliveries, the risk of PPH was lower in the group receiving carbetocin as compared to those receiving oxytocin. And this study is showing comparison with Syntometrine was found to be efficacious as compared to the Syntometrine in the management of postpartum hemorrhage. Now we will be comparing it with Misoprostol plus oxytocin. This study's objective was the effect of sublingual Misoprostol plus oxytocin infusion was compared with the intravenous carbetocin for prevention of PPH in patients with risk factors during cesarean section. The study was done and it was having a sample size of 380 patients who received combined 400 microgram of sublingual Misoprostol plus 20 international units of oxytocin infusion. And the same amount of patient was receiving IV carbetocin 100 microgram. Outcome was found. Other uterotonic requirements, what we were assessing the uterotonics requirement, HB level, and estimated blood loss. Its results were no significant difference was observed. Requirement of additional uterotonics, 13.7% of additional uterotonics were required in carbetocin patient as compared to the 16.3% were requiring additional uterotonics. Pre and post-operative hemoglobin and estimated blood loss. Intravenous carbetocin demonstrated similar efficacy to sublingual Misoprostol plus oxytocin infusion in the prevention of PPH. So guidelines, what are the recommended guidelines nowadays? For the guideline recognizes the benefits of carbetocin. In 2018, WHO shows this that one of the following should use here the listing oxytocin along with carbetocin. Even Canada, Society, Zealand, and FIGO, carbetocin as one of the recommended for PPH management. Germany and France is recommending these guidelines. The final message for my topic is postpartum hemorrhage remains a clinically significant cause of maternal complications and deaths, even in this 21st century. And PPH is now also a common and can occur even in a woman who are not at high risk. Has a major impact on the lives and health of the affected and women and their families. WHO recommends the use of prophylactic uterine as the important steps in the active management of third stage of labor. This can reduce the risk of PPH by more than 40%. Carbetocin is a synthetic, long-standing analog of oxytocin. It's an analog of oxytocin treated by making several modifications in the oxygen molecules. This carbetocin is now available in a room temperature stable formulation and convenient vial presentation. Carbetocin has a similar efficacy and safety profile as that of oxytocin. In addition, it significantly reduces the need for additional interventions and uterine massage. It also reduces the need for additional uterodonics. It reduces the blood loss to less than 500 ml in more women. Champion trial, which was conducted by WHO and taking a sample size of 30,000 women, inferred that carbetocin was non-inferior to oxytocin. It was also compared with Syntometrine and Misoprostol plus oxytocin, which demonstrate significantly better hemoglobin level and lower risk of hypertension and fewer adverse effects. This WHO, FCOG, PIGO, SOGs, and TransOc recommended use of carbetocin in management of PPH. Thank you so much for patient hearing.
Thank you so much, madam. Thanks, doctor. Thank you so much. Yeah. There are some questions which have come. I will ask them. Very elaborate presentation, I must say. Madam, can we really say that you can use carbetocin prophylactically in every delivery?
Yes, according to the studies conducted by WHO, we can use it in every patient. Still now, there is no adverse effects even in heart disease patients, even in asthma patients.
Okay.
Yes.
And who are the patients? Who are the patients who are most, of course, every patient is likely to get PPH, but amongst them, who is the patient who is most likely to get? And PPH is one thing which we do not want in any case in our patients, but then sometimes it happens. But which are the patient groups which are likely to get PPH?
Most importantly, we should definitely use it and we should be ready with the patients who are having twin deliveries, with polyhydramnias, with patients which are having placenta previa or gestosis, hypertension patient. We should be ready with the things.
Uterine atony in short, yeah.
Yes, yes.
And even in fibroids, I think it would be very common. A big lump.
Patients with fibroid and other diseases.
Yes.
Where we we should predict it.
Absolutely.
High risk patient, we should always separate it from the low risk patient. I'm not saying that low risk patient cannot get it.
No.
But the high risk patient, we should be ready with all the things.
But just a different question. You all keep this vial in your in your
yes,
OT
yes.
or yes.
I have this vial in my
the OT, so that because here time is very precious, and yes, we know every second matters. Is there something called as an oxytocin failure? Like suppose someone has used oxytocin in second stage for dilatation, can they use carbetocin for prevention of PPH?
Yes, they can use.
They can use. And is there something called as oxytocin failure or oxytocin fatigue for after prolonged use?
Yes, because the receptors get completely blocked.
And then there is no point in using carbetocin. Suppose if someone doesn't respond to carbetocin, what drug would you normally go for?
I will check whether it is a hypertensive patient or not. If she is a hypertensive patient, I will use methylargometrin. In some patients who are not asthmatic, I can use
Prostaglandins. Yes.
prostaglandins.
Yes.
In some patients, I can use misoprostol, 800 to 1000 microgram pervaginally or sublingually.
Orally you use or intravaginally? Yeah.
Orally.
Orally.
Orally, sublingually.
Sublingually. And with methylation, really the blood pressure changes occurs?
Changes. If she is already hypertensive, then
Okay.
then there will be some changes.
Not otherwise, not in normal.
Not normal.
Not normal. Now, of course, in this is not really a question because we all know cold chain is really an issue everywhere in our country. Even in Mumbai, there is power shortage and power outage and natural transfer. It's really an issue, I suppose, cold chain.
Yes, definitely.
So if you all store carbetocin, oxytocin, you store in the refrigerator.
Yes, and actually my storage is there. Till now, we have oxytocin. And
yeah, of course.
we have all the things. If there is a shortage supply, that UTI and this generators,
Yeah.
But it
Okay.
requires.
Yeah. Also, you will manage it well at your end, but what about distribution channel? I mean, in India, the drugs are transported from where to where, we know. And is there any specific criteria you choose your uterotonics? Like you will prefer carbetocin in a particular group of patient, or maybe methylation in someone, or misoprostol in someone, or you use carbetocin, oxytocin as first line and others as second line?
Carbetocin and oxytocin as a first line drug.
First line, that's right.
First line.
Correct. And carbetocin, although with all this process, has yet to climb to the position of number one. It's still a...
Yes, actually, because of the cost. But
understandable.
Firstly, yes, frankly speaking, I am using carbetocin, but for the high risk cases, at first as a first line drug, and all other patients, I am using oxytocin as a first line.
Understand. Because of the cost. But I think these are all the questions that have come to us. If this is something, we'll come back to you. But thank you so much. It was really very informative and very nice, simple language. You explained everything. Thanks once again. Thank you.
Thank you so much, sir. Thank you for inviting me to for talk.
Our pleasure.
Thank you.
Thank you.
Thank you.